Good morning, everybody. Welcome to Pediatric Grand Rounds. If you're in the Tanglewood complex or anywhere driving by, please come and join us in the Mill Mountain Conference Room. I do see some snacks of some sort in the back of the room, and our sparkling personalities, of course. Today's presenter will be Dr. Kevin Addison. He attended medical school at St. Louis University and completed his pediatric residency at University of Texas in Houston. He completed a neonatology fellowship at Wake Forest University and ended up staying in North Carolina for another 15 years, working at a level 2 nursery just north of Charlotte in the Lake Norman area. Since it only had about 8 beds, Dr. Addison found himself seeing not just the babies in the special care nursery, but also well babies. Nursery closed in 2020, and thankfully for us, he relocated to the Carilion area in October of 2021, and he's been working in the newborn nursery as a hospitalist there since then. Please join me in welcoming Dr. Kevin Addison today.
Hello, good morning. Thank you for having me. Today we are going to be talking about the new guidelines for bilirubin, which came out in the fall of last year. First, the disclosure. So I do not have any financial relationships with any ineligible companies. So these new guidelines, they replace our old guidelines that were published in 2004 and updated again in 2009. They are based on the old guidelines, but they raise the phototherapy threshold by what the committee calls a narrow and safe range. It's separated into 25 key action statements, which I'll be talking about each one of those. So jaundice is actually very common. Quite a few babies actually get jaundice, but what we're worried about is severe hyperbilirubinemia, which can cause Kernicterus. And Kernicterus is worrisome because it's actually permanent. The symptoms that you see with Kernicterus, you get chorioauditory cerebral palsy, you get upward gaze paresis, enamel dysplasia, you can get sensorineural hearing loss, and in addition to that, you can get what's called auditory neuropathy, which interferes with how the brain processes speech and language. So let's go back to about 2004 clinical guidelines. These are the guidelines that most of us are very familiar with, and they are what actually established the nomogram that's currently in EPIC right now with all the various risk factors of our jaundice levels. They had other graphs that were associated with phototherapy guidelines, and here they are. So basically, the very top line of this graph, this was supposed to be for babies who are 38 weeks and greater and had no risk factors. The middle line was for babies who are 38 weeks and greater with risk factors, or a baby who's 35 and 37 to 6 days with no risk factors. And of course, the bottom line would be babies who are 35 to 37 weeks who had risk factors. They have another one for exchange transfusion. And so, one thing that there was some confusion about is there was a lot of different risk factors listed in these guidelines. They had their major risk factors, which talk about, I'll go through some of them. Pre-discharge serum bilirubin, that was in the high-risk zone on that nomogram that's currently in EPIC. Jaundice in the first 24 hours. A DAP positive or other sort of hemolytic disease such as G6PD. Gestational age 35 to 36 weeks. Having a sibling who had phototherapy. A cephalohematoma or severe bruising. And babies who were actually breastfeeding but really not breastfeeding very well and had excessive weight loss. And then they had that East Asian race as well. You have our minor risk factors, and this is babies who have a bilirubin on that nomogram that's in the higher intermediate risk zone, 37 or 38 weeks, jaundice before discharge, previous sibling with jaundice, babies who are macrosomic of an infant of a diabetic mother, moms who are greater than 25, and male gender. And then they had the risk factors that were listed under those graphs, which I shown before. And these are as follows: autoimmune hemolytic disease, G6PD deficiency, asphyxia, significant lethargy, temperature instability, sepsis, acidosis, and a low albumin that's less than 3. So because there was confusion on which risk factors to use, the 2009 guidelines came to kind of clarify that. So they separated out the risk factors into 2 categories. The major and minor risk factors were clustered into risk factors for hyperbilirubinemia, and those risk factors which are listed under the graphs were labeled as neurotoxicity risk factors. And these are risk factors that can increase the risk for brain damage. It was the 2009 guidelines that also established starting a pre-discharge bilirubin screening that now has become standard of care. So our new guides have come out because recent evidence has shown that neurotoxicity actually occurs at higher levels than previously thought. And there's also been some increasing, but still very limited, evidence that phototherapy may not be as benign as we all think it is, and that it can be associated with some very late severe adverse effects, such as epilepsy or cancer. And of course, the biggest thing that phototherapy does is it interferes with the paternal-infant bonding. It's important to remember that evidence is insufficient to actually give exact treatment thresholds, so just like the 2004 guidelines, these are based on expert opinion. So here's our first key action statement. It talks about when to get a blood type and DAT on an infant. And they suggest that you do this for any mom who has a positive antibody screen, or if you don't know the mom's antibody screen. It's important to remember that moms who receive Rogram can have a positive antibody screen, and in fact, this can actually cause the baby to be DAT positive. But of course, if this happens, it doesn't cause any hemolysis. Here's a flow diagram that kind of talks about what to do with this. So of course, on the left-hand side, it talks about, whether or not it was done. And if it was, and it was positive, well, you should get a blood type and a DAT in the baby. The next this big box here, so this is then talking about how to differentiate whether or not the baby's DAT is due to Rogram or not. And of course, the question is, did mom get Rogram or not? And then, of course, if the baby is DAT positive, then you want to be following your jaundice levels quite closely. Now, my partners and I, we talked about all this in the fall. We actually are still using kind of the old guidelines where we get a blood type and a DAT on any baby born to mom who is O or Rh negative. And I think when I get the key action statement number, I think it's 14, I'll explain why we decided to continue to use that method. Key action statement number 2 is not to use water to supplement to try to prevent hyperbilirubinemia. Apparently this is a thing at some point. This was, even in the 2004 guidelines, they said not to do this. So I guess they feel very strongly that you should not give babies water. So some risk factors in the 2022 guidelines are listed that are lower gestational age, jaundice in the first 24 hours, pre-discharge bilirubin that's close to your phototherapy threshold, hemolysis from any cause, phototherapy before discharge, parent or sibling who required phototherapy, history of any sort of red blood cell disorder, cephalohematoma or bruising, Down syndrome, and again, macrosomic infant of a diabetic mother. These new guidelines do stress G6PD quite a bit, to be honest with you. This is an X-linked disorder. It turns out it's actually one of the most important causes of hazardous hyperbilirubinemia, which leads to kernicterus. Most of these babies will not have a family history. Of course, various populations throughout the world are at risk. Those who are in the sub-Saharan Africa, Middle East, Mediterranean, Arabian Peninsula, and the Southeast Asia. I was a little bit surprised at how the number of this. So 13% of African American males have G6PD, and 4% of African American females. Considering the number of African American babies I see in a month, that is implying that I'm seeing quite a few babies who actually have G6PD. So basically, they want you to keep it at the forefront of your mind. If you have a baby who has jaundice, you don't really know why the baby's jaundice, or if you have a baby that you put on intensive phototherapy and it keeps rising, consider checking the G6PD on that baby. So key action statement number 3 is talking about using the serum bilirubin as your primary measure. So if you're going to do phototherapy or extinction infusion, you should do the serum and not the transcutaneous. Key action statement number 4 is suggesting that babies get at least a visual evaluation of jaundice at least every 12 hours within the hospital. And they want to explain that if the baby does get jaundice in the first 24 hours, it's generally due to a hemolytic process. Key action statement number 5 continues the recommendation to get a bilirubin at 24 hours. They actually kind of have a little bit of wiggle room. They say 24 to 48 hours. And I think that's for babies who are born at home. They suggest that they get it at least by 48 hours of life. And of course, you get a bilirubin prior to discharge as well. So key action statement number 5 talks about transcutaneous bilirubins. Previous in the guidelines, there was a special graph that you could look at. You plot your transcutaneous bilirubin, and it would tell you whether or not it was too high, if you had to get a serum bilirubin. So in the current guidelines, you get it if it's within 3 milligrams per deciliter of the phototherapy threshold, or if it's 15 or greater. They also talk about rate of rise. A rapid rate of rise is greater or equal to 0.3 in the first 24 hours, and after that is 0.2. And they suggest that if it is rising rapidly, that if you have not already gotten a DAT, to please get a DAT on the baby. And then key action statement number 8 is talking about follow-up. And basically they're saying that if you cannot get follow-up, you can delay discharge if necessary. And just a little reassuring thing that if you do find that your bilirubin spontaneously decreases, then that would that means that the risk for subsequent severe hyperbilirubinemia is quite low. Key action statement number 9 is talking about outpatient cholestasis, and really this is for those babies who are still jaundiced at 3 to 4 weeks of age if they're breastfeeding, or 2 weeks of age if they're formula feeding. You should, if you haven't already, you should get a not only a total, but you should get a direct bilirubin as well. And hopefully by this time, your state lab has come back and you'll be able to see if there's any sort of metabolic disorder that might be causing the baby to be jaundiced. So now we're getting to phototherapy, which is our main treatment of jaundice, and this causes, it facilitates excretion of your bilirubin products, and that's how it decreases your jaundice level. And it's effective depending on how much skin is being exposed, and of course the intensity of the phototherapy. They do recommend that you use at least 30 microwatts per centimeter squared, and the wavelength should be approximately 475 nanometers. So key action statement number 10, now we're getting into the new phototherapy threshold graphs, and they do give you some wiggle room that if you feel, because of the particular clinical circumstances, that you want to start phototherapy before you're actually at the phototherapy threshold, of course you can do that. But they do kind of warn you that just be aware that there are risks to overtreatment. So here's our first graph. So as you can see, it's a little bit different than the 2004. Each and every gestation has its own graph. So let's see if we can look at we'll go to 24 hours. Actually, I want to go to the next one. Let's see. So basically, they split up these graphs into two graphs. You have a 1 to 3 day and a 3 to 14 day. So let's look on this one. So we're going to go to a 38-weeker. Has approximately, I would say about 12.2, 12.3 is when you're supposed to start phototherapy at 24 weeks. I'm sorry, 24 weeks, 24 hours. And a 35-weeker is going to be approximately 10.5. So I know when I first looked at those numbers, they looked quite high to me, but these are what the new recommendations suggest. And so we've been following them really probably since about October of last year. Again, they have another graph more for an outpatient where they like 3 to 14. And now, so I apologize, I need to clarify. These graphs are all for babies who have no risk factors, no neurotoxicity risk factors at all. And now we're going to talk about what are the neurotoxicity risk factors. So gestational age less than 38 weeks is considered to be one, but it's important to remember that gestational age is already included in the previous graphs. So if the baby's only risk factor is gestational age, you would use the graph that's for a baby with no risk factors. Albumin less than 3, but there really is not enough data to actually recommend getting an albumin on every baby. Of course, babies who are DAT positive or G6PD, sepsis, or clinical instability in the previous 24 hours. So here are the graphs for babies with risk factors. It's important to note that, as you see, they only have up to 38 weeks and above, rather than having a separate one for 39 and 40 weeks. And that's because the committee decided that although 39 and 40 weekers are at a less risk for having hyperbilirubinemia, they're not at less risk for having neurotoxicity. So you look at these numbers. Let's go to the next one. Here we go. So this one, 24 hours, a 38-weeker, we're now about 10.5, and a 35-weeker, we're down to just below 9. So it's about 1.5 to 2 lower for babies with risk factors than babies without risk factors. There's another outpatient one. So home phototherapy. So they do recommend that you can do home phototherapy, but they have several criteria that you need to follow according to these guidelines. So first of all, they want the babies to be 38 weeks or greater. They want the babies to be at least 48 hours old, and clinically well and feeding well. No neurotoxicity risk factors. No previous phototherapy. A serum bilirubin that's no more than 1 milligram per deciliter above your threshold. And the LED device should be available without delay. They don't really specify what that means. What does that mean? 6 hours, 12 hours? They don't really specify. So, and then a serum bilirubin should be measured daily if you're doing home phototherapy. So how frequently should you monitor your serum bilirubin? And this is for babies who are on phototherapy. So they recommend within 12 hours after starting it if the baby's in the hospital. I'll be honest, we actually probably do it far more frequently than that. And really they base on how often or how frequently you should do it based on all the various risk factors that the baby may have. So when do you admit a baby for inpatient, if the baby's getting outpatient phototherapy? Well, basically, if your phototherapy is increasing at a greater rate than the graph says it should be increasing, or if the serum bilirubin is greater or equal to 1 above the phototherapy threshold, then yeah, that's not a typo. They, you can do home phototherapy if it's no more than 1, but you have to admit if it's 1 or greater. So I guess at 1, you kind of do what you feel is best. So they recommend that you get some labs when you start a baby on phototherapy, including a CBC or H&H to get a baseline in case the baby has anemia. And then this is where, this is the key action statement on why my partners and I are still getting a blood type and a DAT on any baby born to moms who are O or D18 or Rh negative, because it basically says that if you start a baby on phototherapy and you have not already gotten a blood type in DAT, you should get a blood type in DAT on moms who are O and Rh negative. But as you saw previously, those two graphs, babies who have risk factors, you start phototherapy 1.5 to 2 milligrams per deciliter lower than babies who do not have risk factors. So if you start a baby on phototherapy and find out, oh, he's actually DAT positive, well, you're kind of behind the cart at that point. So that's why we just get it right off the bat, just like we always have. Get it if the mom's O or Rh negative. And again, if you don't know, if the baby's jaundice and there's really no good cause, I mean, this is fairly severe jaundice, not just mild jaundice, or the serum bilirubin continues to climb despite really intensive phototherapy, again, keep G6PD in mind. So when you stop phototherapy, this is actually a fairly conservative recommendation. They want you to stop phototherapy once the serum bilirubin has dropped to at least 2 milligrams below where the hour-specific threshold of where you started phototherapy. So, for an example, this is, if you start a baby at an hour-specific threshold of 12, as all of us know, it doesn't just instantly start going down. It kind of continues to climb up slowly but surely. Most often it'll go up, 12.5, 13, and then slowly but surely it'll go up to 14, and then, maybe 14.3, start to level off, and it'll start to go down, and then, so, getting it down all the way down to 10, it can take quite a while, and so I'll be honest, we don't always get down to this level in terms of sending a baby home because the baby would just have to be there for, be in the hospital for just too long sometimes. Now, of course, this is baby specific. If the baby has a lot of risk factors, if this was a 35-weeker with who comes positive, I probably would be very conservative and when I would stop the phototherapy. And again, that's what they said in the next line. So rebound. So they have a very different definition of rebound than I think what most people use. So their definition is rebound is if the serum bilirubin reaches phototherapy levels at 72 to 96 hours after stopping phototherapy. At least for me, my definition of rebound is I stop phototherapy, it bounces back up again, that's rebound. But this is how they define it. The risk factors for rebound are, or if you start phototherapy less than 48 hours, hemolytic disease, or if the baby is 38 weeks. As you see, there's a very wide range on what the overall risk for rebound is, between 4.6 and 24%. So key action statement number 16 is talking about when the recheck, and it's just based on, how likely you think the baby is to rebound. And so high-risk babies, you should get check-in in 6 to 12 hours. Babies who are not at high risk, you can check it the next day. And in fact, they do mention that if it's at least been 24 hours after the phototherapy has been stopped, you can check a transcutaneous bilirubin as well. So now we're getting into escalation of care. This is something that they talk about when you're getting close to exchange transfusion thresholds. So if you're within 2 of your exchange transfusion thresholds, you start getting quite a bit more intensive. They want you to send some labs, such as, of course, a total and direct bilirubin, CBC, albumin, chemistries, and of course, get the baby type to be cross-matched. And they do recommend that you start these babies on IV fluids, and that if you're not at a place that can do exchange transfusion, you need to transfer the baby to a place that can do that. And they do recommend that when you're in this escalation of care threshold, you should be checking your jaundice level every 2 hours. So IVIG, so they do say that for babies who have isoimmune hemolytic disease, you can give IVIG, but they kind of have a cautionary note in that it's a little bit unclear on just how effective IVIG is. And apparently there's been some observational studies that show that IVIG can be at risk for NEC, which is for people who don't know, that's necrotizing enterocolitis. So here's a flow diagram for escalation of care. It's basically everything I was just talking about. Of course, the very first thing, are you at the right location to do exchange to infusion? If not, please transfer. And then you send a bunch of labs. Now, over here on the right, it talks about, obviously if your serum bilirubin gets over the exchange to infusion threshold, you're going to start an exchange to infusion. But also, if the baby is showing signs of encephalopathy, even if you're not quite to that level, you definitely want to urgently start an exchange infusion as well. And then they do mention that if the serum bilirubin drops below the escalation of care, well, then you can just go back to what you were doing before. But if not, you just keep doing what you've been doing with escalation of care, basically until you either do exchange transfusion or you are no longer in your escalation of care category. So what are the signs of encephalopathy that you need to worry about? So babies, they're hypertonic, they have arching, they can have retrocollis, and they can have epistotonus. Those are actually all three fairly similar. So arching is of the back, retrocollis is arching of the neck, and epistotonus is basically arching of both of them. Babies can have a high-pitched cry, and they can also have recurrent apnea. So this is all what we've been talking about, the key action statement number 3. And they do advise that if you get, if the bilirubin gets above your exchange transfusion threshold, but then as anybody who's done an exchange transfusion knows, it's not an immediate thing. It takes a little bit of time to get everything ready. And so if while you're getting things ready, your bilirubin drops below the exchange transfusion threshold, it's okay to hold off and not do the exchange transfusion, but continue to follow very closely. But of course, if the baby's showing any signs of encephalopathy, you need to immediately do an exchange transfusion no matter what the letter looks like. So here are our graphs for exchange transfusion. This is the one for no risk factors. So let's see, our numbers, 48 hours, our 38-weeker is up to 24, and our 35-weeker is about 20 and a half or so. And again, they separate it out by days 1 to 3 and days 3 to 14. And here is exchange transfusions with risk factors. So over 48 hours, so a 38-weeker drops down to 20, and a 35-weeker drops down to about 18 and a half or so. Again, days 1 to 3 and so the blood products that they recommend that you use if you have to do an exchange transfusion is you mix packed red blood cells with fresh frozen plasma, and they recommend you mix it to a hematocrit of 40%. And the reason why they recommend the 40% is the additional FFP that you use to make it 40% has albumin in it, and the extra albumin will actually help with bilirubin removal. So now we're going to talk about follow-up. They have, the next page we're going to be talking about what when to follow up with what, depending on what your level of jaundice is, level of bilirubin below the phototherapy threshold. And you're not supposed to actually use this figure for babies who got phototherapy during the hospital stay. I think it's kind of supposed to use your own judgment at that point. So this is actually a very useful table because it, at least for me, in terms of when a baby needs a follow-up, depending on his jaundice level. So they give you 0.1 to 1.9. So they basically recommend that the baby is 24 hours old. You can consider phototherapy if you want to. Or you can just continue to follow it closely. If the baby's over 24 hours old, they can give some options that you can, of course you can start phototherapy again, But you can also consider home phototherapy or discharge without phototherapy with close follow-up. I'm unlikely to do either one of these two. I'm most likely going to either be following the baby very closely in the hospital, or I'm going to be starting the baby on phototherapy if I'm that close to the phototherapy curve. This next 1, 2 to 3.4 milligrams below your threshold. This is, you just continue to follow the bilirubin. Generally with these, I've been keeping them in the hospital as well. I mean, I guess theoretically, if you get a bilirubin at like 6 p.m., you could theoretically have the baby follow up the next day in clinic. But I've just been keeping these babies in the hospital. You can get a little bit stuck sometimes. I've had babies where they end up being 2 below the threshold. You check it again in 6 to 8 hours, still 2 below the threshold. You check it again, and finally, you know, oftentimes my partner and I would just end up throwing the baby on a Billy blanket. It goes down, and we send the baby home at that point. So this next one, 3.5 to 5.4, this is generally where I want it to be in order for me to send the baby home. Because as you see, the follow-up is in 1 to 2 days. And in fact, generally, I prefer it to be closer to 4 if I can, just to get that little bit extra buffer. And of course, as you get higher numbers, you see your follow-up gets a little bit more, you know, get a little bit more flexibility in your follow-up, such that if it's greater than 7, you know, you can follow up in 3 days if you want to. All right. So the last key action statement is talking about family handouts. And I'll be honest, I've kind of dropped the ball on this a little bit. I did a similar presentation to this in the fall, and we got all of our nurses and staff, you know, onto these new guidelines. But unfortunately, I forgot about the family handout. So thankfully, I'm doing our grand rounds, which reminded me of this. So we are starting to work on this now, getting the family handouts. At this time, they're not really part of EPIC, and so the nurses have to write everything in. So I'm not sure how successful that's going to be until we can actually get it as part of this, our normal discharge packet. But we're definitely going to start working on making sure that this happens. So I now want to talk about the Billy tool that we all use in the hospital. So all those graphs are fantastic. They're very nice, very colorful. But we live in a digital age. So mostly what we use is at billytool.org. Now, I guess I should say I don't know who owns billytool.org. I do not have any financial relationship to it. Generally, how I find it is I just go to Google and I just type in Billytool 2022. And again, I don't have any financial relationship with Google either, for that matter. But it's a very nice app. I don't know if am I able to get on the internet with this computer?
We can if you escape out of this, yeah.
Let me quickly show you how. What's our time? Yeah, we got a little bit of time. So. Alright, so as you see, you have 2 options of entering bilirubin. The top option I generally don't use, but you have to enter, let's see, 1, 2, 3, 4, 4 things in. And so I generally end up using the bottom option, and so you put the hour of age. So like, say for example, I'll do a baby who is 36 hours of age, and I'll go ahead and do a bilirubin of 14, and then you choose the gestational age, and I'm going to make this a 36-weeker, and then whether or not the baby has any neurotoxicity risk factors, and again, they're very nice. They list them up here so that you can see what they are in case you forget. And then, so we're going to say no. And so this tells me that I do need to start this baby on phototherapy because my threshold was 13.1. And so we're going to go back and we're going to reset. We'll do a 36-weeker and we'll just do 10 and now this tells me that I don't need to start phototherapy, but the baby is 3.1 milligrams below the threshold, which then tells me, so they recommended me that I should get another bilirubin 4 to 24 hours from now. The other very nice thing about this is that if you can enter a transcutaneous bilirubin as well, let's see, I think, so we'll do the same thing, 36 hours, and we'll make this, let's see, 13, same thing, 36 weeks. So now you see the transcutaneous bilirubin, it is within 3 of your threshold, so that's in red, and it'll tell you that they get a serum bilirubin. You can also do rate of rise with this tool, and the way you do that, I'm going to put in 24, 36, and I'll put in, we'll put in 7, 12. Again, we'll just stick with the 36 weeks. And then it gives you that the baby's rate of rise is 0.42, which is high. So, of course, if you have not, if you don't already have a DAT, make sure you get a blood type and a DAT on this infant. So we just found that this is a very useful website. Makes it very easy, at least until Epic eventually integrates the new guidelines with Epic. Okay. So, let's see. All right. So now I was told I have to prepare questions. Here is our first one. So according to our 2022 guidelines, what percentage of African American males has G6PD? So, let's see, yes, thank you. All right, I'm not very good at doing questions. All right, number 2, which of the following is not a risk factor for developing significant hyperbilirubinemia? You have phototherapy before discharge, jaundice in the first 24 hours, cyclohematoma or bruising, Down syndrome, or parent or sibling required phototherapy. B, that's right. There should be jaundice in the first 24 hours. You're absolutely right. All right. Now, last one. So now you have a 4-day-old newborn in clinic with elevated bilirubin, and you want to start the baby on home phototherapy. So according to our new guidelines, what is required to qualify for home phototherapy? Baby gestational age 37 weeks or greater, serum bilirubin no more than 2 above the threshold, baby supplementing, breastfeeding babies are being supplemented, no nerve tracker, or the LED device will be available within 48 hours. Is it the D? Yes. All right. Is there any questions I can answer for anybody? Yes. Or anything?
What blood do you prefer for exchange transfusion?
What blood?
Yeah, either babies or moms.
Well, generally, what they are suggesting is that you use a cross-matched blood, is what the new guidelines recommend. Is whatever blood when you did the typing screen is what they're recommending. But I do know what you're talking about. That sometimes they do recommend using oftentimes they just recommend using O-negative blood, to be honest with you, because that's the safest, most benign. But in these guidelines, they suggest just using whatever the cross-match blood is. All right, yes, sir.
Did you mention what were the concerns for risks with phototherapy in the long term?
Yeah, in the very beginning, and so they said there are some limited evidence that there could be some risks that can cause like epilepsy or cancer would be the long-term risk. But again, it's very limited, and they state the guidelines do say that those guidelines that the evidence is increasing. I can go back to that slide if you'd like me to.
That's fine.
Okay. Yes,
I noticed it talked about albumin levels. Under what circumstances would I have had a reason to check the albumin level?
yeah, that's, I'll be honest, that's more for a baby who's in the NICU already, because they specifically mention that there's not yet enough evidence to warrant getting an albumin on every baby. So this is only a baby that that's most likely very sick, and you're already going to be checking the albumin level. In the newborn nursery, this is not something I'm going to be checking on a regular basis, no. Yes, sir.
The oral rehydration that you perform while escalating if you're close to an exchange transfusion threshold.
It was IV hydration, I think is what.
So it's both. On two different tables it said use both. Do you know what the oral solution is, or is it just formula? Because I would assume you already gave
I think it was just IV hydration.
You went past it?
Yeah. Did I pass it? I
The opinion
apologize.
does say to do both.
Right here, you mean?
Yeah, the third box down on the left,
Oh,
second
okay.
bullet point.
Yeah, so that would just be, whatever the baby's been feeding, breastfeeding or formula. Yeah, nothing special.
Would you do like Pedialyte ever?
For a baby, no, I wouldn't. I mean, no, I would not, no.
Just mentioning it in there, because they mentioned it in 3 different boxes on the slide, it seems redundant to the point it's confusing, because you're already giving these babies as much,
Yeah.
volume as they'll take from what they're feeding.
Years ago, that was just standard of care, that every baby that went in for phototherapy, double phototherapy, had to have an IV.
Right.
So it was like you were trying to sort of flush them out.
Yeah, because the most common, one of the very common reasons is babies can get a little bit dehydrated from breastfeeding, and so that's, you figure, oh, the baby's dehydrated, but we don't really do that as much anymore. But obviously when it gets severe, they still recommend that you do that, yes.
It almost makes me wonder if it's almost code, because, we're so pushing towards breastfeeding only, but if a mom's only making colostrum, this isn't going to hydrate the baby.
Right.
So are they saying, go ahead and increase your PO hydration as well?
Yeah, I mean, exactly, but of course, that's only when you're in the escalation of care period, are they recommending that. If the baby's just, getting phototherapy, they're currently not recommending, stopping breastfeeding and doing formula feeding or anything like that.
When you do exchange transfusion, you don't give PO feeding, right?
Well, I mean, if the baby's capable, I guess you can, but again, that's not, you're doing IV fluids, and hopefully you're doing it at a rate that the baby is getting plenty of fluids. But I guess if the baby does want to eat, I guess you could do that. But really, most babies at that level they're not feeling very good at that time.
We have a question in the chat. Dr. Kreider says, what expectations are being given at discharge for biliary checks? We do not routinely check TSBs at Phototherapy because getting a value on a healthy 3-day-old greater than 15 obligates us to get a TSB. This may require us to send a patient who lives more than an hour from RMH to RMH for a stat bili, which is the only way to get a stat bili for us. If we have a high suspicion of need for phototherapy, we check the TCB.
Yeah, well, a TCB is certainly an acceptable alternative in terms of checking it. As we all know, a TCB is a wonderful tool. It's very convenient, and it's fairly accurate when you compare TCB to TCB, but it oftentimes is higher than a serum bilirubin. So you do run the risk that you're going to get to that point where you will need to get a serum bilirubin anyways. But I think it's just a screening tool when a baby comes to the clinic. I think a TCB is a great place to start. But do be aware that if baby recently got phototherapy, phototherapy does interfere with the transcutaneous bilirubin because, of course, phototherapy works on the skin first.
Does it cause a rebound in the TCB levels post-phototherapy?
That's a good question. Yeah, whether or not the TCB rises faster than the serum bilirubin, I don't really have an answer for that. I don't know.
I don't think it does. I think it's because the risk there that you're going to miss it. You're going to miss somebody whose serum bili is higher than the threshold to admit or to use the phototherapy because you're looking at the TCB, which is low, because they already got phototherapy, but after that 48 hours, the new guidelines say you can use it again.
I remember somebody doing a journal club or something on it last year about there's a certain timeline where you can't use it.
Yes, 48 hours.
And then
So
but
once
something
they
about
stop.
rebounding.
I don't know why you would rebound into the skin. That doesn't make any sense.
Typically, I think you're afraid you'll miss the rebound if you check a transcutaneous too early because it will be falsely low since you cleared the skin of it.
And Dr. Carter, I see what expectations are being given at discharge for biliary checks?
Well, we generally, it depends on what our, how close we are to the threshold, but oftentimes I am sending a baby and telling them, follow up tomorrow for a jaundice check, or follow up in 1 to 2 days for a jaundice check. If we're not very close to the threshold, I'm generally, just follow, and I'm not telling them specifically to follow up for jaundice. But our new guidelines, of course, recommend that, if the baby, of course, looks jaundice, that you should definitely be keeping that in mind and should be following up the guidelines. But in terms of what we're telling the parents when they're leaving the hospital, it's only for babies who are closer to the threshold that we'd be telling them that they need to get jaundice tests in clinic. Any other questions, Dr. Hazel? Well, thank you very much.
Thank you.